Hello everyone, I am Dr. Mohammad Akheel. I am a head and neck surgical oncologist. I basically specialize in oral cancers. My topic will be oral cancers and insight. Welcome to my DLC talk, guys. India is the world capital of oral cancers. Globally, oral cancers rank 6th most common of all types of cancers. India has 1/3 of this global oral cancer burden. Out of this, in India, when you compare the central part of India, the states like Madhya Pradesh, Gujarat, and West Bengal have the most number of oral cancers. This is the statistics of Indian Council of Medical Research, ICMR. So, coming to the etiology of this cancer, tobacco is the main etiology of this oral cancer. We have something called a human papilloma virus. This is called HPV virus, which is the most common in the western part. HPV virus is transmitted and spread by explicit sexual behaviors. So this virus is also one of the main etiological factor. You have something called malnutrition. Oral cancer is most commonly seen in low socioeconomic status because of malnutrition. So these are the generalized etiological factors causing oral cancer. When a person is having a tobacco, or when a person is smoking, or when a person is having an alcohol drinking, in the due course of time, if he develops a red patch, which is called as an erythroplakia, or if he develops a white patch, which is called as a leukoplakia, or a combination of a red and white patch, or if he develops an ulcer, or if he develops a tumor anywhere in any part of the oral cavity, he must seek a medical help immediately rather than to wait and watch. Basically, in the initial stages of these symptoms, there is no pain, so people ignore their symptoms and doesn't seek medical advice, which can land them in a problem. So they have to approach their family dentist, or they have to approach a family physician who can guide them to a head and neck surgical oncologist who specializes in this oral cancer. Some other symptoms which are most common, which are classified as a pre-malignant conditions, are oral submucous fibrosis. In this condition, the patients have a reduced mouth opening over a gradual period of time. There are patients who don't have any illicit habits, who don't have any tobacco chewing, nor they have any other habits, but still they develop this cancer. But these symptoms are, which I have told, which is common to everyone. So whenever you see the symptoms, it is very important to seek the medical help as early as possible. The second thing is, if you have an ulcer in your mouth, you approach to a doctor. When do you approach to a doctor? So these ulcers can be healed within 2 weeks of time. If it is a normal ulcer, it can heal within 2 to 4 weeks of time. If an ulcer is staying above 4 weeks, that means it is going in a wrong direction. So at that time, you need to approach your medical personnel. When the ulcer or when the tumor starts, it starts with a very small area and then gradually it spreads into the whole oral cavity, into the adjacent structures. When it spreads, the cancerous cells, it comes down the neck. We have something called lymph nodes. The lymph nodes takes up the cancerous cells and they get infected. So we need to examine the oral cavity as well as the neck. The neck, you have the lymph nodes. So the diagnosis of this cancer is based on clinical, and we need to confirm this. We take a biopsy. Many people get afraid that they say that if you take a biopsy, the cancer spreads. No, it's a myth. The cancer, it doesn't spread. So we do a biopsy. Biopsy can be of varied types. The most important and most conclusive biopsy is a punch biopsy. We take a small amount of the tissue from any part of the tumor, which we think is more susceptible to cancer. So we take up the tissue, we send it for the lab, we get the report in 48 hours, and we just keep it in front of the patient that it's a cancer or it's not a cancer. So this is the diagnostic part. Then we do a radiological investigations. We do a CT scan or we do an MRI scan. CT scan is most commonly done for the heart issues like the upper jaw, lower jaw. MRI is done for the buccal mucosa cancers as well as the tongue cancers. So based on the MRI and CT, we come to know that what is the exact extent of the tumor, from where it has started, from where it has spread, what are the lymph node significance, whether they are significant, whether the MRI says or the CT says that cancer has spread into the neck or not. And this radiological investigation gives us a roadmap to perform a surgery, what structures to remove, what structures not to remove. Stage 1, stage 2, third stage and fourth stage. There are 4 stages in oral cancers. So based on this staging and the radiological investigations, we plan the management. Now what are the management part? Management, the conventional management are surgery, radiation and chemotherapy. Surgery stays the main mode of management in oral cancers, and surgery is minimal when you come early, like in stage 1 and 2. Surgery is a huge or bigger when you comes in advanced stage cancers. Mostly in India, we see 1 lakh new patients diagnosed with cancer every year, and out of that 70 to 80% of these patients are in advanced stage. So we need to have certain guidelines, and we need to have a certain oral health screening camps to generate an awareness among these public and bring them and tell them that you need an urgent medical help. So coming to my treatment, surgery forms the main important role. Now the surgery is done, you get the report in 1 week. Based on the final report, you plan what additional treatment you have to do, whether the patient needs a chemotherapy and a radiation therapy. Coming to the newer advancements in what we have in the oral cancer, we have advancements in every field. Like in surgical part, 10 years down the lane, we used to do a flaps reconstruction, because cancer is an ablative procedure. We remove some important aspect of the face which helps in the function and the cosmesis. So we need to put something in that to enhance the patient's cosmesis, or to balance the patient's microarchitecture. So we used to take flaps from the chest, forehead. But now in the recent era, we have something called microvascular surgery. The advances have been tremendous in microvascular surgery. We have very good plastic surgeons who are taking the bone from the leg and making the mandible and reconstructing it. Then we have advancement in the radiation. Radiation, 10 years down the lane, there was a cobalt radiation. Basically, this cobalt radiation also have a very good control, local control, but the thing matters is about the side effects. After the radiation is completed, the side effects are very deleterious. So we need to have some newer technology to control the side effects. Then came the IGRT, which is the latest one. In between we had an IMRT. So IGRT is image guided radiation therapy. We take images every day and modify our radiation beam to prevent the side effects. We give radiation only to that particular area where we want to give. Coming to the chemotherapy part, we had a conventional chemotherapy called methotrexate, a single agent chemotherapy around 10 years back. But now we have so many types of chemotherapies. We have single agent, double agent. We can add chemotherapies to improve the prognosis, and basically chemotherapy, a higher grade of chemotherapy are given before the surgery to downstage the tumor in advanced cancers like stage 4, and then do the surgery for improving the prognosis of the patients. Coming to the chemotherapy part, we are going something ahead. We have a targeted chemotherapy. Targeted chemotherapy is based on the molecular biomarkers. We have something called EGFR, epidermal growth factor receptors. EGFRs are very well established in literature in lung cancers, but oral cancers, it is not established. So we are trying to review the literature on EGFR and making an chemotherapeutical agent which will target the EGFR agents and bring down the cancer. So these are the latest things. Coming to the radiological part, we just had an X-ray, as you know, around 20 years back, but now we have a PET CT scan, positron emission tomography, along with a combination of CT scan. PET CT scan is the ultimate scan which will tell where is the cancer and where the cancer has spread. It is a one scan which scans from the head to toe, and you will know the exact values with the help of an uptake of the contrast, and you can plan your modality of the treatment. So out of this, I want to tell that when the patient comes in the early stages, as we are talking, my DLC talk is about early detection. I want to emphasize on the point of early detection. So when the patient comes in the early stages, like first stage and the second stage, there is a complete cure. But when the patient comes in the advanced stages like third stage and fourth stage, the cure rate comes down. For the stage 4, it is hardly around 50%, and that patient might need radiation, surgery as well as chemotherapy. So my DLC talk is on early detection of the oral cancer. Oral health screening camps has been conducted and are being conducted by so many doctors across the India. There are anti-tobacco campaigns being done. So we are trying to educate the people that tobacco is not good for health. So if you are having tobacco, please kindly quit it now. And if your friends or relatives or anyone among your family members are having the tobacco, you need to educate them and tell them the consequences of this tobacco chewing, and you need to enforce them to stop tobacco now. I would like to thank Della Leaders Club for having me here and giving me a golden opportunity to talk about oral cancer and insight. And I hope it was very insightful for you. Thank you so much.